Now let's switch gears again and talk more about pressure and how it's regulated throughout the body. First, let's talk about atrial natriuretic peptide, or ANP. This is a peptide that the atria release in response to increased blood volume or higher pressure. And it leads to vascular relaxation. ANP is one of the few hormones that actually helps to lower blood pressure, since most of the hormones keep blood pressure up. As the kidneys are coupled to controlling blood pressure, it is important to think about its effect on the kidneys. ANP constricts the efferent renal arterioles, dilates the afferent arterioles, and increases excretion of sodium in water, thereby promoting urine production, or diuresis. Baroreceptors and chemoreceptors are stretch receptors that control the short regulation of blood pressure. There are receptors in both the aortic arch and in the carotid sinus that are always active. The aortic receptors only respond to elevated blood pressure and communicate this to the brain via the vagus nerve. Here's a short review question back to neuro. Which cranial nerve is the vagus nerve? That's right, it's cranial nerve 10. The carotid sinus transmits via cranial nerve 9 or the glossopharyngeal nerve and can respond both to an increase and decrease in blood pressure. These signals are then transmitted to the brain's vasomotor center. Baroreceptors work by sensing decreased stretch, which decreases their firing rate. This results in decreased parasympathetic activity to the heart and increased sympathetic activity to the heart and blood vessels. This increases heart rate, contractility, and vasoconstriction, which all increase blood pressure. This mechanism can be exploited clinically with the carotid massage maneuver, in which rubbing the carotids increases pressure on the carotid artery, thereby increasing stretch and afferent baroreceptor firing. This can cause decreased heart rate, blood pressure, and even syncope if you're not careful. This is a useful maneuver to abolish certain arrhythmias. On the other hand, peripheral chemoreceptors sense arterial oxygen, CO2, and pH levels, and they transmit this information to the brain in order to regulate breathing. They are located here in the bifurcation of the carotid arteries and aortic arch. They are extremely sensitive to decreases in oxygen partial pressure, increases in CO2 partial pressure, and decrease of blood pH. These signals result in vasoconstriction. As you will learn in the neurology section, there are also central chemoreceptors. As a preview, these respond to changes in pH and CO2 of brain interstitial fluid, which is influenced by arterial CO2. Unlike the peripheral chemoreceptors, these central chemoreceptors do not respond to oxygen. Next, let's go over blood circulation to the organs. The lung receives the largest blood flow, receiving 100% of cardiac output. The liver gets the most systemic cardiac output, or blood, and the kidney gets the most cardiac output per gram of tissue. The heart extracts almost all of the oxygen in the blood. This means that the only way to increase oxygen when there is increased demand for the heart is to increase coronary blood flow. The next image shows the normal pressures in the heart as measured by a pulmonary artery catheter. It's not terribly important for you to know these numbers, but you should remember that pulmonary capillary wedge pressure is an approximation of left atrial pressure and therefore left ventricular diastolic pressure, and that can appear in many questions. Also, with certain pathologies like mitral stenosis, this approximation might not be true. For example, in mitral stenosis, pulmonary capillary wedge pressure is greater than the left ventricle diastolic pressure. When it comes to autoregulation of blood flow, each organ has its own way of maintaining its blood supply. You can read the specifics here, but the general idea is that organs increase their blood flow by vasodilation when perfusion pressure falls. The one exception to this rule is in the lungs, where hypoxia actually leads to vasoconstriction, with the idea being not to waste blood flow on an area of the lung that's poorly ventilated. This concept will be discussed in more detail in the respiratory section. Finally, we'll round out our discussion of cardiac physiology with a quick review of capillary fluid exchange. This tends to be an extremely high-yield fact for the exam, and a proper understanding of this information is absolutely necessary for numerous cardiac diseases. Basically, in any capillary bed, there is a balance between four pressures that try to drive fluid in or out of the vessel. Starling forces are one of the most important physiologic principles to understand because they relate to a number of different pathological states. This is high yield. As you can see here, capillary pressure and interstitial fluid colloid osmotic pressure result in fluid movement out of capillaries, while interstitial fluid pressure and plasma colloid osmotic pressure result in fluid movement into capillaries. The net flow of fluid in or out of a capillary also depends on the permeability of the capillary, given by the filtration constant. It is important to know this equation relating these concepts. One clinically useful way to think about capillary fluid movement is to consider edema, the excess of fluid in the interstitium. Edema results from any state in which there is an imbalance in the forces keeping fluid within vessels versus the forces pushing fluid out of the vessels. How could heart failure result in edema? Heart failure leads to an increase in venous pressure and an increase in capillary pressure both in the pulmonary vasculature and in the periphery. This increase in capillary pressure favors filtration out of the capillary, and therefore, as you can see, heart failure results in both pulmonary edema and peripheral edema. What diseases might lead to a decrease in the concentration of plasma proteins, and therefore lead to edema because of a decrease in the plasma colloid osmotic pressure? Well, nephrotic syndrome due to loss of protein in the urine and liver failure due to decrease in plasma protein synthesis both lead to decrease in the concentration of plasma proteins. A decrease in plasma proteins means there is a decrease in plasma colloid osmotic pressure, increasing filtration out of the capillary. Okay, what conditions can cause an increase in capillary permeability, leading to edema? Well, toxins, infections, and burns can all lead to an increase in the filtration constant and increase in capillary permeability, leading to edema. Finally, why might lymphatic blockage, such as after a radical mastectomy, lead to edema? Well, when you have lymphatic blockage, there's an increase in the interstitial colloid osmotic pressure, leading to edema. This ends our discussion about the cardiac physiology and anatomy. Next, we'll move on to the pathophysiology.